Thank you. Good morning. Welcome to Orlando. It's a beautiful day out there, so hopefully you get to enjoy some of Central Florida's weather. And for those of you that got a chance to see our hospital last night, we're proud of it and we're excited about what we're building here. And I'm excited to, one of the reasons I came here from Charlotte, North Carolina, where I'd practiced for 15 years, was to work with people like Richard Finkel, who really phenomenal world leader in understanding muscle and nerve diseases. And that's something that I've always been interested in. And CMT in particular, I'm interested in because, quite frankly, I don't really understand it all that well. Why do these things happen to children and adults for their musculoskeletal system, the things I'm interested in, so their backs, their hips, as we heard the question I walked in at the last panel. And then a lot of foot issues and hand issues. So I'm going to go over that a little bit and then hopefully have some time. I'm going to drink some coffee. I was on call last night and operated until late in the evening, or morning, I guess earlier this morning. I was awake operating, so it's good to be with you. And if while I'm talking I say something that really gets you going, just raise your hand and we can have questions while I'm going. So I don't have any conflicts or financial issues. You guys know more about this than I do, and certainly Dr. Finkel does, but it is helpful when I've taught residents for my 15 years in Charlotte, and they need to know what CMT is and how it's classified, and how it's classified helps us for the type 1. It's really where the musculoskeletal problems are going to be, and primarily foot problems for type 1 patients. And then type 2 patients have a little bit different. They often have more weakness and more of a flail foot and a little bit of a different lower extremity pattern. The type 3 kids show up earlier. It's an infantile form, and they're often very weak, and so we have to help them more with bracing and physical therapy support. And then the other types, and each one has specific issues that we try to think about orthopedically. Here are the big orthopedic issues. For me, number one, part of it is probably because my research interests are in childhood foot disorders. So I see lots and lots of foot problems. And North Carolina had as you all know, genetic issues with CMT, and we had a lot of families with CMT in North Carolina. So I took care of both adults and children when I was in North Carolina. Here in Orlando, I'm not sure how eventually I might get to where I can take care of some adults, but right now our children's hospital is 18 and under by the founding charter of our hospital. So, and I actually missed that. I really enjoyed taking care of adults with CMT when I was in Charlotte. But so the foot's by far the most common thing. Hand involvement is common. And the numbers that are in the orthopedic textbooks are 10, 10, and 10. I don't think that's really very well studied, and hand involvement in particular is more common, I think, than 10%. I think the numbers for scoliosis and hip dysplasia are probably about right for the number of patients who have significant problems that might need to be treated. It probably is somewhere around 1 in 10. But as I would teach the residents, if you see a patient that has a motor and nerve problem, every time you examine them, you should look at their hands, their feet, their spine, and their hips. And there's certain things that we do to look for those problems. Occasionally, those things need surgery, and I'll talk to you a little bit about that. But the most important thing, for me and for any other physician taking care of patients is take a good history. How are you doing? What's bothering you? What are your issues? Do a good physical examination. And then take x-rays where they're indicated when we know that certain things happen with a certain frequency. So in my practice, every child that has Charcot-Marie-Tooth at some point is going to get an x-ray of their hips, even if they're not symptomatic, because the problem with hip dysplasia is silent. And so the kids don't complain of pain. They often don't limp from their hips. It can be difficult when they're limping because maybe they have bad feet to say, well, is a limp from their feet or is a limp from their hips? But in general, I heard Dr. Finkel, he gets an A for his orthopedic knowledge, say that it doesn't generally happen in babies. So hip dysplasia and Charcot-Marie-Tooth is not what we see in little babies. Every little baby that's born, pediatricians in North America are taught check their hips for instability, where the ball's going in and out of the socket, the hip's too loose. That's what we call typical congenital hip dysplasia or now better termed developmental hip dysplasia. In Charcot-Marie-Tooth, hip dysplasia develops over time and is probably related to weakness around the hip girdle musculature, leading to abnormal forces across the growing hip, leading to the hip not developing normally. And that's one thing that we don't understand very well, how that happens. But it clearly happens with greater frequency in children that have Charcot-Marie-Tooth get hip dysplasia than in children that don't have Charcot-Marie-Tooth. And this is what it looks like. So you all can see that, right? So I showed these pictures and well, that looks pretty okay to me. But to an orthopedic surgeon, it looks bad because the ball is not covered well by the socket. So it actually, nothing's broken, everything's lined up pretty well, the limb lengths are pretty equal, but this is an abnormal hip that has the socket is too shallow and its slope goes uphill too much. So we in orthopedics draw some lines we love to draw lines and measure angles. And so this angle is too much. It should be about 40 degrees. And essentially this is a ball that over time is going to slide up out of the socket and get too much stress on a focal area of the hip and lead to hip arthritis and then lead to probably getting a hip replacement. So the question is, we don't have enough information to say that every time on this child with this x-ray who's going to be in my clinic, Monday morning. Because to fix this, there's no simple fix to make this better, to prevent the hip replacement. To go back to the question from the last session, something should be done to prevent this. Well, yes, when we're confident that we have a good solution that will prevent it, and the risks and the benefits are aligned appropriately. So the benefits of doing something to try and prevent hip arthritis are better rather than the risks. So we also get special x-rays. So if you get an x-ray of that same child from the side, you really see how shallow this socket is. The socket of the hip joint should go more than 50% over the front of the femoral head from this view. And so it's really an anteriorly deficient socket, and that leads to abnormal forces and can lead to early arthritis. It should look like that one on the right. But so we agree that looks abnormal. Well, how do we fix it? Well, this is how you fix it. And this is no small operation. This is 5 hours of surgery, cutting the pelvis all the way around the socket, rotating the socket so it better covers the bone. And there's lots of things around there that you're cutting, the sciatic nerve, the femoral artery, all of those things have been reported to be injured with this particular operation. And it doesn't make every hip better. Some people still have pain and some people still get early arthritis. So we are much, much better. Yes?
What's the recovery time for surgery like?
That surgery would, patient would be in the hospital for probably 2 nights, would be on crutches for 4 to 6 weeks. And in general, it would take about 3 months for that to heal to the point that they would be walking on it fully. And depending on how you do the surgery and what happens with the hip musculature, it probably would be 6 months before they're walking really well without any kind of assistive device. And then you have to figure out on top of that, well, how are they walking beforehand and what is their strength? So if you have a patient that you're doing this on that has CMT and already has some weakness, having them have a big surgery and then not move for 3 months often leads to further weakness and further problems. So it can be it might be a year. So it may be a year before you really get all the benefits of the surgery. But that's a good question. So that's hip dysplasia. The other thing that every child with CMT should be checked for is scoliosis. So a lot of people have heard about scoliosis, and a lot of people are afraid of scoliosis. But in general, mild scoliosis is really not a very big health hazard. Many people have mild curvature in their spine. It doesn't make your spine weak. It doesn't make you more likely to have paralysis or weakness. It's just a curve in your spine. But it can cause some problems, and it causes trunk shift. It causes lower shoulders. And this is the way you examine is just look at them from the back. Every child in an orthopedic exam who has CMT should be looked at from the back. And then they should do this test where they bend forward. And we look to see how much curvature there is. And then I'm going to show you what's called the Adams forward bend test. Often they have one side higher than the other. This girl has 2 curves, and so she's kind of balanced her trunk out. But these are the problems with scoliosis. Your trunk shift, your head's off to the side, and that can lead to muscle imbalance, muscle pains, But it's hard to tell. So many people have back pain. 80% of adults in the United States miss work at some point in their life because they have bad back pain. Does scoliosis increase your risk of back pain or not? We don't really know, because everybody gets back pain at some point. But it kind of makes sense that if your back is out of balance, that some of your muscles are going to work harder, and balancing your spine might lead to lower back pain. This is the test that all of you can do on any of your family members. You can just look at them from the back, tell them to bend over and touch their toes. And if you see a big hump and it's rotated, that's a sign that they have a scoliosis, a curvature of their spine. Because although scoliosis is defined as a curve to the right or the left, it's really a rotational deformity. And so in addition to curving to the right or the left, the trunk twists. And it's that twist that's most important in terms of the deformity. It's the twist that's most important in terms of diagnosing it. So that's why we do this test. You bend forward, you'll see that their trunk is twisted, and one side is higher than the other one. If you see the twist, you get an x-ray. So just like I said, we don't always x-ray the children in the clinic with CMT, but they should get an exam, and if their trunk looks twisted, they should go get an x-ray. And this is what scoliosis looks like. This is old surgery for scoliosis, not very successful. Now we have very powerful instrumentation and very safe surgical techniques with monitoring of the spinal cord, and we can basically, instead of grabbing the spine at one area here and one area here and sort of stretching it apart, which doesn't correct the deformity well and is dangerous to your spinal cord and neural elements, now we can grab the spine at every level with a screw and put 2 rods in instead of 1, and we can take a very crooked, stiff spine and make it really pretty straight. That's no little operation. So that's 4 to 8 hours of surgery, and that's usually 4 to 5 days in the hospital, and that's 3 to 6 months to heal. And again, every decision we make in medicine, there's risks and there's benefits, and what are the risks and what are the benefits, and when the benefits are way better than the risks, then maybe surgery is what you need. So that's scoliosis. This has been my interest in CMT, and is management of foot deformities and trying to understand them. And they typically, but not always, I was talking to one of the attendees last night, not every patient with CMT has a cavo varus foot. They can have foot deformities and foot problems that aren't cavo varus. And so just because you don't have a high arch doesn't mean you don't have CMT, and just because you have a high arch, it doesn't mean you have CMT. So if you do have the high arch, though, it's not a very accepting foot deformity. So what we call a cavo varus foot, a high arch, I'm going to talk to you, it disrupts what we call the tripod of the foot. It makes you walk on the outside of your foot, and it makes your foot rigid. And so if any of you have children that have CMT and they have a cavo varus foot, and you have a 2-story house, you can tell when they're walking around upstairs because they can't walk softly. It sounds like you have an elephant in your house. And that's because the foot becomes very rigid and it doesn't accept the shock absorber. A flat foot, which many of you may have heard of, lots and lots of people have flat feet. I see hundreds of children every year for flat foot complaints. Flat feet are normal. Flat feet are supple. Flat feet are very flexible. They take up shock absorption, which is one of the jobs of your foot. And so orthopedically, I really don't worry much about flat feet. I would much rather have patients that have flat feet than have a cavo varus high arch foot. And it's because of this. So when you walk on the outside of your foot, it's basically like walking on a peg. It doesn't accept any of the shock absorption that normally happens when you go heel toe in normal gait. And that causes pain and problems. And if you get a really high arch foot, we don't have very good shoes to accommodate that deformity. So many of you in this room know what this looks like. And so this is a very typical Charcot-Marie-Tooth cavo varus foot. A very high arch, increased plantar flexion or pointing down of the first ray, which you can see I'm pushing up on it here, trying to see how flexible it is. Extreme tightness of the plantar fascia and the little muscles on the bottom of the foot. Clawing of the toes. And so this is a very typical foot deformity, and Dr. Finkel and some of the other physicians who are talking to you guys are helping us try to figure out why does this happen and what goes on. The intrinsic muscles of your foot has, just like your hand, has what we call intrinsic muscles. Those are muscles that originate and insert in the hand or in the foot. And in your hand, those muscles do this. They bend your fingers down at the knuckles, and they keep the joints in your fingers straight, so they do that. And so when those intrinsic muscles stop working, your hand starts to do that. It starts to claw, okay? And why the intrinsic muscles get weak first? Is it just because they're furthest away and the myelin isn't normal? And so those are questions for the smarter doctors that are talking to you, not the orthopedic surgeon. But that's what's interesting to me. I don't know why the intrinsics go first, and then the foot, the intrinsics, the tibialis anterior, and then the peroneus brevis get weak, and it's always on our board test as to what the order is, and that's usually the order they give. I'm not sure that that's actually the order, but those three muscle groups getting weak leads to a drop foot, to plantar flexion of the first ray and a high arch, and to clawing of your toes. Yeah, there's a question back there? Well, what happens, plantar fasciitis is very common. It's pain right there in your heel. It hurts the first step in the morning, feels like somebody stabbed you in the bottom of your foot. And having a high arch, it's not related, I don't think, to the neurological issues with CMT. It's related to the biomechanical issues that you get a high arch and this stuff gets tighter, so it's stretched more when you're walking on it. And I think that people with high arch feet do get more plantar fasciitis. But lots of people get plantar fasciitis, you know, and I had it for years, relatively miserable when you do have it. So, but those structures are important, and I think that the plantar fascia and the ligaments, I don't think are the pathology here. The pathology is in the muscles and the nerves that then put the foot in a position where it doesn't get stretched and those ligaments then get tight. But if, as a surgeon, I want to make this better, I have to take care of all those tight structures in addition to trying to balance the foot. So this is what I just talked to you about. You lose the intrinsics, tibialis anterior, and the peroneals. You get a cavovarus foot. When we treat this orthopedically, we have to look at how flexible the foot is. In general, cavovarus foot deformities and Charcot-Marie-Tooth foot deformities are driven by the forefoot and the midfoot, and the hind foot is just along for the ride. So the hind foot is your heel bone, and your talus, your ankle joint. And so in young children, I almost always can operate just on the hind foot and the soft tissues, the tight structures, and I don't have to do the heel nearly as commonly as in adults. The hind foot's been following along for 20 years, and I usually have to do surgery on the hind foot and the calcaneus too, and I'll show you that. I think especially in kids, this is an important thing. The problem here is muscle balance, so the foot gets imbalanced. And so if you have an imbalanced foot, if you do surgery on it and you don't try to balance the muscles that are remaining that are working, it might just pull back into the same deformity. And by far, the biggest frustration I have with trying to operate on cavovarus feet and make them better is recurrent deformity. So trying to balance the foot is important. And the principle is if you have a muscle that's working well and it's pulling the foot in, don't let it keep pulling the foot in. Move it somewhere else where it can help pull the foot straight. And so that's what we mean by not wasting a motor. Don't waste a muscle. Someone I was talking to last night is on your board, and they were talking about, it's not a physician, was talking to doctors about different things and how they have to dumb it down so that the board member could understand it. And I say, that's what I feel like when I talk to Richard Finkel. I'm like, okay, bring it down here to this level that I can understand. So, but if you think about your foot, it's really not very hard what the job of your foot is. You need a stable platform to stand on, and you need to be able to get one foot in front of the other without dragging it or tripping over it, okay? And those two things. So when I teach your residents, the first part of a good orthopedic physical examination is you open the door and you go out in the hallway and say, walk up and walk down, and the kids are always embarrassed and they're holding their little gown and they're walking funny, and mom's always going, walk normal, whatever that is. I don't know what walk normal means. That's like I tell the mom, I say, okay, mom, breathe normally. What is that? So we don't think about walking just like we don't think about breathing. So all you moms who are telling your children to walk normal, stop it. But this is the problem with cavovarus feet. So it's not a stable platform to stand on. That bone, the big toe bone pointing down, makes the foot twist out to the side. You're basically walking on the outside of your foot. You're kind of rolling your ankle all the time. And so you don't have a stable platform to stand on. So that's problem number one. And that's because of this. It's called the tripod effect. So normally, and there's probably a couple little arrows here. I'll just click through that. So normally what happens when you stand on your foot is that the first metatarsal, the big toe bone, the fifth metatarsal, and the heel all should hit the ground at the same time. If the big toe bone hits the ground first, it makes your heel twist out to the side, and you end up with a cavo-varus foot. And so that's where I was telling you before, the forefoot, the front part of the foot, the metatarsals are driving what happens to the hind foot, the heel bone, and the heel bone's just along for the ride. So, and this is what it looks like when it gets really bad. This bone's been hitting the ground first, then the fifth toe bone hits, then the heel twists into what we call varus, meaning it points outward, and this foot is stuck like this. This is an adult from my practice in Charlotte, and this is a terrible foot to walk around on. Not a stable platform. To get this, you just walk on this. And so, you get a bad callus underneath the fifth metatarsal head. It hurts. You can get stress fractures there. I'll show you a picture of that. And so if you're in the office and you have and this is one of those things Dr. Finkel talked about, let the parents educate the doctors. If you have a good orthopedic surgeon and they're looking at a varus foot from the back, they're going to put this block under there. And basically what they're trying to do is make sure that the first bone doesn't hit the ground at the same time. So you put this underneath the fifth metatarsal, and so now the first metatarsal and the fifth metatarsal are going to hit the ground at the same time, and your tripod's not going to twist. And then you can look at the heel. And you can see in this patient's heel, my pointer has just decided to die. So if you put that block under there and the heel stays crooked, then we know that the heel is now stuck. So this heel is twisted out a little bit and it gets pretty straight. So this is probably a foot where I don't have to cut the bone of the heel bone, and I can just do surgery on the forefoot and lengthen the plantar fascia and the tight plantar structures and get away with less surgery for this patient. That's why we do it. So, and that's a good sign. So if your orthopedic surgeon says, let's get you to stand on it, they're not crazy, they're doing a good job. That's what they should be doing. You can get calluses everywhere. This one's under the first metatarsal head where that big toe bone's hitting the ground first. And there's some bones there called the sesamoids that can become painful. Claw toes are very common. They can become painful as your shoe wears on the top of the PIP joint of the toes. This is an example. If you walk on that outside of your foot long enough, you can get a stress fracture. So this is a stress fracture. If you get a stress fracture and you have a cavo-varus foot and they put you in a cast and think it's going to get better without correcting your cavo-varus foot, it's not going to get better. So you got to operate on the foot and correct the alignment, the biomechanics, or this stress fracture is just, you got to change the stress. So stress fractures show that things are bad. You can also get to where your ankle rolls out. Every time you're rolling all the time, you can stretch all these ligaments, and this is the peroneal tendons that help hold your ankle stable on the outside of your ankle. So it's common in adults to get peroneal tendon pathology in addition to the ankle sprains. So this is a very common position in shoes. You wear out the outside of your shoes. Often patients with CMT have to wear high-top shoes. This drop foot leads to the second problem, which is if you can't pull your foot up, that's where you can't clear your foot. So you drag your toes. She's got some little skin changes on her toes, and she's having difficulty clearing her foot. So not only does she have a bad platform to stand on, now she can't get one foot in front of the other. And those are the things that lead me. One of the questions someone asked last night is, well, when do you have surgery for CMT in your feet? Well, when your feet are bothering you enough that the benefits of surgery outweigh the risks, because there are risks and benefits. But if you have functional problems, you don't have stability in stance, you don't have clearance in swing, you can't manage that with an orthotic, then for me, that's when we start talking about, let's do a surgery, and what surgery should we do? So that drop foot, when she pulls this is the best she can do to sort of what we call dorsiflex, or pull her foot up. And you see what happens is, as this tendon right here is the tibialis anterior that gets weak, and as it gets weaker, it can't pull the foot all the way up. There's another tendon on the outside called the peroneus longus. Those two tendons are what we call antagonists. So this one's pulling it up. There's a tendon that inserts on the bottom of this bone pulling it down. This one's winning. So it's pulled this bone way down. Big toe bone hits the ground first. But when she tries to walk, and you can watch them if you watch them walk barefoot, when they're swinging their foot, their toes go way up in the air like this. And that's because those toe extensors are trying to help. They're trying to pull that foot up so they don't drag their foot, so they get clearance and swing. The problem with that is that since the intrinsics don't work to keep those toes flexed down at the knuckle joint, at the metatarsophalangeal joint, it leads to clawing of their toes. So the more that this tendon on the top pulls, the more this thing's going to bend and become clawed, and so you get in this vicious cycle. One of the things, I just show this again, so you have to look at kids. You can't, if the orthopedic surgeon never makes you walk, never makes you stand on your feet, they're not doing a good job. If the problem is foot deformity, you got to see them standing, you got to see them walking. We always get x-rays to assess the bony alignment. This, you can see, this patient has the hind foot is in a really bad position, has been falling along too long. This is unusual, actually, in CMT. Most CMT patients look more like this, where the heel bone's pretty normal, and the problem is this first metatarsal or big toe bone just goes straight down. That's the problem. You can actually get that same test. You can put the block on their foot to see if the foot lines up better. And again, this is helping us make decisions about where and what kind of surgery we might do to move that foot around. You see that without the block, this bone is way over here. When they stand on the block, that foot comes back into a more normal position. All right, so cavo-varus feet, they're stiff. Non-operative treatment, braces, shoe wear can be helpful, but it doesn't fix the problem. And this is often in North Carolina. I noticed there's some better looking shoes here. But I had a real challenge. You take a young teenage girl that paints her toenails like this, you tell her to wear that, not going to happen. Not going to happen. So, and they don't want to wear a brace. You know, teenagers do not want to be different. They don't want to wear a brace. And so that's the real issue. So often, you know, the inability to accept wearing a brace it can be an issue, and that's a complicated discussion. We have to have that, because I can't always guarantee you with the surgery that you're not going to need a brace for two things, right? For stability and stance and clearance and swing. I can't promise that to everybody. That certainly is my goal, but I may transfer a muscle, the tibialis posterior muscle. Again, the smarter doctors in the room have to explain it to me, but it is preserved in CMT most of the time and seems to be one of the last muscles to get weak. So I use it a lot to transfer, to try and take advantage of that motor and prevent recurrent deformity. But that muscle can get CMT changes too. And if it gets weak, you get recurrent deformity, I might tell you have to wear a brace. So I can't always promise that you won't have to wear a brace. So these are things that are mainly directed at orthopedic surgeons, to have them know that the principles are deformity correction and muscle balance. And muscle, the main thing for orthopedic surgeons to know is that you can't do soft tissue only muscle surgery and correct fixed deformity most of the time. And you can never do a muscle tendon transfer and expect that that muscle is going to correct the deformity over time. So you got to correct the deformity first, and then you can do the muscle balancing, muscle tendon transfers. So often, and this is where, you know, this is the orthopedic part that comes from experience and knowledge, and is that you have to do all those tests, examine the foot, look at those x-rays, put the block under there, watch them walk, and figure out, do I have to do soft tissue? Do I need to cut the bones? We try not to fuse or do an arthrodesis of joints if we can avoid it. Very frequently, when people see that the toes hit the ground first, the simplest thing in orthopedics is to lengthen the Achilles tendon. It usually doesn't need to be lengthened in CMT. So it's probably the most common surgical error I see, is that people go to someone and all they get done is an Achilles tendon lengthening, and they haven't fixed the toe going down and the high arch and all those things. And in really young kids, in my practice, sometimes I can just correct their deformity by putting a cast on and changing it every week or two for a while and stretching out the bones and the tissues. Muscle balancing, these are the principles. That if you have a muscle that quits working, I can't, you don't have spares. You have things that we can move around and use, but they're not designed to do the exact same thing, so it's always a little weaker. It really never is going to be completely normal when you have a tendon transfer. But if you have a muscle that's pulling the foot into deformity and you leave it there and don't do something about it after you correct the deformity, it's probably going to pull the foot right back into the same deformity. So you got to do something to those muscles to change the deforming forces, either lengthen the muscle or transfer it. And then I mentioned you can't just do transfers to. So this is what a CMT surgery looks like. We've cut the first metatarsal to line it up with the talus, and so we dorsiflexed it, had a stress fracture that was fixed over here, had a calcaneal osteotomy as an adult to move the heel back over underneath the tibia, and very typical series of operations. This is what your plantar fascia looks like if you've never seen it. This little white stuff right here. This is the heel. The foot's looking at you just like this. So this is the heel down here. The toes are up here. And I like to lengthen it through a transverse incision where I can see it all. There's some little nerves nearby, but there's lots of ways to lengthen the plantar fascia. It heals usually with a nice scar. If you make it in the front off the heel pad, it doesn't seem to hurt people. And I'm going to quickly go through, I've been talking for about 25 minutes or so. And just show you some pictures of what different surgeries look like and then have some questions. But the one principle, if you're standing, is that your heel bone should be underneath your leg bone. Okay? Again, this is orthopedics, so it's not rocket science. So some real simple concepts help us. If you're standing, your foot and your heel should be under your leg. Shouldn't be way to the inside or way to the outside. So the one way you can do that is you can cut the heel bone and just shift it over. And the other way, you can cut it and bend it. So those are just examples of heel osteotomies. They usually do if you put them in right. So if you put them in right, where they're not going across the joint and they're not sticking out too far and they're not down here on the weight-bearing surface, but sometimes they bother people, and once the bone's healed, you can take them out. But elective removal of metal is not usually needed in orthopedics. If you have a rod, screw, plate that's in and is put in the right place and it's not hurting you, there's really no advantage to taking it out. This is that first metatarsal, so we cut that big toe bone and pull it up. That's a common surgery that we do. This we try to avoid. So this is a fusion. This is called triple arthrodesis. It used to be the most commonly done surgery for cavo-varus feet and CMT, where you fuse the talonavicular joint, the calcaneocuboid joint, and the subtalar joint, or the talocalcaneal joint. So those are the three joints. You fuse all three of those. It's really bad because this can happen. It's a hard operation to get perfect. If you leave some of those muscles and they pull what's left into a little bit of malalignment, then it puts all the stress on your ankle joint. And so then this bone right here should be flat like this. So this is awful ankle arthritis. And this patient actually came to me and her foot's pointing straight down. She's a banker, and she was told she should have an amputation. And she didn't need that, but she did have an awful ankle joint, and so she actually got a fusion and put her foot back flat. Again, gave her a stable platform to stand on. And she's very happy, very happy. But she has a very stiff foot, and we call that a pan-talar fusion. That's not a very good operation to have. So we try not to do fusions if we can avoid it. In young patients, we can often just do soft tissue. So this is a young boy that had cavo-varus feet and had tendon transfers, so had plantar fascia lengthening, serial casting to correct his deformity, and then moved his tibialis posterior from the back of the leg through this incision to the front, and then pulled it down and sewed it in the top of his foot. So it's my timer telling me to quit talking. If you have this surgery in an older patient, it's a lot of surgery. And raise your hand if you have stubbed your toe ever in your life. Does it hurt? This is like stub your toe times 1,000,000. Okay? So this is 21 incisions to correct a bad Charcot-Marie-Tooth foot in a 20-year-old male. Okay? Who's having pain, who's dragging his foot, and so this is pre and post surgery. So here, this heals in a little bit of varus. This one now you can see is in valgus, the right alignment, but you can't see, but every toe now is straight, has an incision on it. We moved his tendon to the front. It's a lot of surgery. It looks like this in the OR. So we straighten all the toes and put wires in them. We fuse the big toe joint and move it to the first metatarsal to pull it up. We cut the first metatarsal. We lengthen the plantar fascia. This is a lot of surgery. And afterwards, it's just what it looked like healed. So these are the don't look if you don't like bloody pictures series. But this is what the soft tissue release to cut the plantar fascia. You can do it this way on the inside of the foot. There are lots of structures there that are important. This is where you go a little bit deeper. If you have a more rigid foot, you still don't always have to cut the bones just because you have rigid deformity, but you have to do more soft tissue lengthening and lengthen all the little intrinsic muscles on the bottom of the foot, and even open up the talonavicular joint. I think this part's really important. So where you cut, here's the big toe bone. So if you can get enough correction through this bone that's behind the first metatarsal, they do better because the second metatarsal doesn't get as much stress if you cut the bone back here. So one of the complications of cutting the first metatarsal is you just move the stress over to the second metatarsal and they get a stress fracture. So I try to do the osteotomy there if I can do it to correct it. Sometimes you get a really bad deformity that's, you know, a 25-year-old, the feet have been like this a long time. There's no way that you're not going to correct this without taking out big chunks of bone like this and then straightening that forefoot. But if you can do that, that's better than, and I think, so fusions aren't always fusions. So I told you before, we don't like to do triple arthrodesis fusions. That's these big joints right here and at the ankle joint and here. Little joints in the foot and the toe joints, you can fuse them. They don't take up a lot of stress. And so if you fuse them, you're not going to have a lot of stress transfer to the other joints. And then here's just what tendon transfers look like. Tendons are these white things that are attached to the muscles, and you can take tendons that are doing something bad and move them to somewhere where they will help. And that's really the principles of tendon transfers. There's lots of different tendons that we move around in Charcot-Marie-Tooth patients. And here's before and after. So here's a varus foot walking on the outside, now has a straight. The heel's now underneath the tibia. You know, here you can see some of the scars along the medial foot. The high arch on this side, you can see. And so we want the foot to be flat, be underneath the leg, and you can see the scars from the tendon transfers. It's not little surgery to have a Charcot-Marie-Tooth foot reconstruction. So foot deformities are common. They're related to this progressive muscle weakness and loss of the muscle, quote, what we call the balance around the foot. They're often progressive and disabling. You know, it's a stiff foot to walk on, it hurts, you get calluses and stress fractures. If it is really symptomatic and shoe wear, braces, cushions don't help, then I think surgery can be helpful. But every foot is different, and so you really need careful analysis of what, it's not one operation. It's not like you have hip arthritis, you get a total hip. You have knee arthritis, you get a total knee. It's not like that at all. Cavovarus feet are complicated, and every operation needs to get individualized for the specific patient's issues. So with that, I will, my email's there if anybody has any questions. I left some cards on that table. I am on call, and I have to go back to the ER after I finish this talk, and so I don't know if, hopefully I'll make it back for lunch, but if I don't, you're welcome to email me any questions, and again, my card's out there as well. So thanks for your attention, and I'll take some questions.
So we only have time for maybe one or two questions. Okay, I see a hand here. Anybody else raising their hand? Okay, I have one up here.
Doctor, I've had many surgeries like triple arthrodesis, Jones tendon transfer and such as a child and as an adult. I've never found any, let alone any other specialist, any orthopedic doctor who would say they would take CMT into account when they're doing the surgery. What you're saying about muscle balance and transfers, they claim they do whatever procedure they do, and they don't even research CMT. And they say they know it, but they show that they don't. Now, how can you convince them? I'm considering a surgery now, and that when I asked I'm not going to use him now, but when I asked the doctor, would you please have your staff research CMT and see if it makes a difference in the procedure you're proposing? And he said angrily, no, I won't. So what can I do to convince a doctor to really understand this and see if there's any differences than if it was a normal
Well, I think
patient?
that,
I don't need
I don't know, I
just
just,
a pointer.
physicians go through a lot of education and get a lot of training and do all that, and then sometimes I think leads them to think that because they've done all that, someone else might not have a better idea. And so it's not uncommon, especially for surgeons, to, this is how I handled this problem. And I think it's about education and educating physicians, and to some degree you might be able to help educate them, but it sounds to me like you have someone that sort of thinks that they know it and they don't want to be educated. And I really don't know how to handle that problem from a patient's perspective. As an educator, yeah, I mean, he said get a different doctor. So, but I think you can. I think the issues are, for me, are really about, I don't know how to change CMT yet. I don't know how to change what we call the natural history, is what happens with Charcot-Marie-Tooth patients as they get older, to their muscle function, to their musculoskeletal alignment. And so taking that into consideration when you do the surgeries, I think, is important. So if you have a really strong deforming muscle, I'm not going to leave that muscle alone and just correct your foot. I'm going to do something with that muscle to make it not a deforming force and hopefully help me prevent relapse of the deformity. That principle is not something that, you know, I hope that all the residents that I've taught about CMT understand that, but a lot of surgeons may not know that. Someone had a question in the back? Yes? Okay. Okay.
I think as a support group leader, the question I hear the most and read online the most is, when do I have my first surgery? And I think it's something parents deal with. The complication rate for surgery seems to be pretty high for our population. Do you find that to be true, or is it just more anecdotal? And what can we do to decrease our infection risk and things like that? Thank you.
Sure. Well, I think the infection risk should really be pretty low. I mean, I think that wound healing problems, which are not the same as infection, may be higher because we're cutting tight things and then stretching them. So you're stretching all these incisions. And so I think wound healing problems, but wound healing problems get better. They just take a little bit of time, and wounds will heal. Even awful, terrible looking wounds with time will fill in and heal. I think the biggest complications I see are recurrent deformity or failure to get all the correction that we want to get in surgery. And let me tell you, I mean, it's heartbreaking for parents. It's heartbreaking for the surgeon. I hate when my patients don't do well after I put them through a big surgery. And so I always tell them, you know, I'm not telling you you're going to have one surgery. You're going to have one surgery. I'm going to do my very best to make it perfect, but there's a good chance that either it won't be perfect and we need a tune-up surgery, or that your disease is going to get worse and this is going to come back earlier than we would like for it to come back, and I might have to do something a few years down the road. But I think again, it's about education, and I'm trying to understand and it's different for every patient. You can't move the tibialis posterior to the front of the foot on a patient who can't actively move their foot in before surgery. So just to do that, because a book says do this for CMT, that's the problem. So you have to individualize the surgery to every patient.
Dr. Frick, could you give us your email again?
Oh, sure. It's just Stephen with a V, .frick, F-R-I-C-K, @nemours.org.
So if you have any other questions,
And there's
please.
I left a bunch of cards on the table out there, too.
And will you be back for a lunch with the experts?
Depends on how the ER goes.
Okay, we hope
I will
so.
try.
We hope you. Thank you for such a wonderful talk.
Thank you.